Cancer Biomedicine BSc taster session. Thank you all so much for coming. My name is Emma Last. I'm a current second year Cancer Biomedicine student and your chair for today's session. We're hoping that this will help answer any program specific questions you have. We will have a Q&A later, so you can drop your questions in the Q&A chat throughout, and also just give you an insight into what it's really like to study on our program. So today our speaker, Dr. Ursula McGovern, will give you an insight into cancer biology, cancer medicine, and help you find out what we're doing here at the UCL Cancer Institute and what you could get involved in during the program. She'll also provide a summary of the Cancer Biomedicine program, including modules and entry requirements, etc. This session is being recorded and will be sent to you after the session, so you can go back and watch it whenever you need to. Now, to introduce our speaker, we have Dr. Ursula McGovern. She is a consultant medical oncologist at University College Hospitals, and she was appointed a consultant in 2011. She completed oncology training in London, obtaining a PhD in molecular oncology from Imperial College. She specializes in the treatment of prostate and bladder cancers and helps lead clinical trials in men's advanced prostate cancer, and also patients with bladder cancer. She collaborates with other centres in the UK and international centres. In her role at UCL, she is a professor and she leads the UCL Medical School Oncology training, and she is also the programme director for BSc Cancer Biomedicine. So to hand over to Ursula, thank you so much. Yeah.
Thanks, Emma. Hi, everyone. So welcome to our taster session. So I'm just going to share my screen so you can hopefully see my slides. And thanks, Emma, for the introduction. So as Emma sort of said, I wear two hats really. I'm a working oncologist at UCLH and I treat men with prostate and bladder cancer, but I'm also quite heavily involved in the teaching that's delivered at UCL, and I ran the Cancer Biomedicine program here at UCL, and I'm also the lead for our medical student teaching in oncology. So we've got a very typical sort of role. There's lots of us here who work part of our week as doctors and then part of our week with the university and teaching our students. So just thinking about cancer, this is a disease that's been around for an awful long time. We've known about cancer for thousands of years, literally, and we know that the oldest ever case that we know about was of a case of leukemia, and this is back in a Neolithic woman, 5,000 years BC. So this is not a new disease, and it's been mentioned in antiquity, in Egyptian papyri. But actually, if you think about it, although we've known about cancer for literally thousands of years, it's probably only in the last century or so that we've actually had good treatments for it. And it's been a bit of a conundrum for many centuries, because there's been so much research, you know, why do people get cancer? What causes it? How does it happen? How can we prevent it? And again, you know, a lot of what we're doing is really only evolved over the last 50 or so years. So it's been around a long time, but actually our treatments and our intervention is relatively new. And if we think about cancer, you know, what is happening when someone develops cancer? So basically, we're thinking at the cellular level. It's when cells, abnormal cells, start to divide in an uncontrolled way. And these cells may eventually spread to other tissues, and we get what we call metastatic disease. And there are literally hundreds of types of different cancer. If we think about in the UK, the most common cancers are breast, prostate, lung and colorectal, and that accounts for a significant proportion of the cases that we see. But there are lots of very rare types of cancer as well, so more than 200 different types of cancer. So we've got a poll that I'm hoping is going to work. So our first question for you, and we pop the poll up and hopefully you'll be able to try and answer this. So 1 in 2 people in the UK will get cancer. So that's a bit of a scary statistic. So feel free, go ahead and vote. And we'll just give it a little while to see how many people. I think we've got 17 on the call, so we'll just give it a little bit longer. So at the moment, we've got everyone opting for true. So we'll end the poll. Yep, so 92% of you think it's true, 1 in 2 will get cancer, 8% think it's false. I can see someone's raised their hand. I can't see the chat. Emma or Kate, can you see, is there a question?
Not in the chat right now. No.
Okay, all right, well, I'll just carry on, sorry. Okay, so well done, everyone. So you said 1 in 2 people get cancer in the UK, and that is actually a true statistic. So that's a little bit frightening, but if we try and get it into the context of what we're doing, we're saying, yes, it's common, 1 in 2 of us will be diagnosed with cancer. But I think it's a really important message to get across that actually lots of people survive their cancer diagnosis. So don't assume a diagnosis of cancer means that patients are going to die from their disease. If we diagnose them nice and early, we can get them onto good treatment, operate, etc., they're very likely to survive. So although it's a common condition, our survival rates are getting much better. So why is that statistic so high? Why have we got 1 in 2 people in the UK developing cancer? And probably from our point of view, it's a lot to do with age. So we know in the UK, we have an aging population. So people are living longer. And the biggest risk factor for developing cancer is getting older. So if we're seeing an aging population, we're tending to see more and more cases of cancer as the risk goes up with age. But I would keep hammering home this message. Just because we're seeing more of it doesn't mean our outcomes are getting worse because of the bigger numbers, and actually we're doing much better. So you're much more likely now to survive cancer than perhaps if you were diagnosed in the 1970s. So we're really getting somewhere with our treatments and our earlier interventions. But putting it in context of numbers, I mean, you know, we see an awful lot of patients every year. So our clinics are very, very busy. You know, there's over sort of 350,000 cases plus of cancer diagnosed in the UK every year. And I've said most of them, or at least half, are within those common cancers. So you're looking at breast, prostate, lung and bowel cancer. And you can see here the peak rate of cancer cases. So, you know, it is very much a disease of older people, but you must remember anyone really of any age can develop cancer. So we do see all different age groups developing cancer. So thinking about treatment, because I guess if you're thinking about a career in cancer research, or you're thinking about this as a degree course for you, we're thinking about what can we do to help our patients and how can we treat their underlying diagnosis. So there's different treatment options for cancer. So we think about surgery, we think about chemotherapies, that's what I often give, I'm a medical oncologist, or we can think about radiotherapy, and very often actually patients will have a combination of all three. So my patients, for example, with bladder cancer, they might have an operation to have their bladder removed. I may give them chemotherapy before or after their operation. They may have radiotherapy to consolidate that. So it's not unusual that actually patients get lots of different combinations of treatment. And we are changing the way we're thinking about our treatments, because if you think about chemotherapy, it's not very specific or sensitive, but actually we're now starting to look at cancers on an individual basis, and perhaps we talk about this concept of personalised treatment. So some particular patients may have a particular molecular feature or a genetic characteristic that makes them more responsive to certain treatments. So we're definitely moving much more towards individualised treatment for cancer. And that's why it's quite an exciting field to go into at the moment, because an awful lot of the research that's been done is about more personalised, targeted treatments for cancer. So thinking a little bit about chemotherapy. So what does chemotherapy do? So chemotherapy is trying to target any cell that rapidly divides. So very good for treating cancer cells, which are rapidly growing out of control. But the problem with chemotherapy, it's going to kill any cells that do that. So it's going to try and damage DNA beyond repair, stop the cell going through the cell cycle and prevent that cell from dividing. So very effective treatment for cancer cells, but also is going to affect normal cells as well. And chemotherapy drugs can work in lots of different ways, and I'm sure most of you are doing biology, so you'll know about DNA synthesis, DNA replication. So what we're trying to do is target the sort of division of these cells at different levels and by different mechanisms. And often we give more than one chemotherapy drug. So we might give a drug that inhibits or poisons the mitotic spindle. We may give it in combination with a drug that interferes with DNA replication. And by the multiple hits on the cell, you get a very good kill effect, and that's how chemotherapy has its effect. So very common that we actually give combinations of chemotherapy drugs to patients to try and get a maximum benefit in terms of trying to kill off those cancer cells. But I've said the problem is that we also kill off normal cells as well. So chemotherapy, as you probably all know, does have side effects. And so when I see a patient in clinic and I'm talking to them about potential side effects, this would be a very typical list of what I might go through with a patient. So not unusual to feel a bit tired on treatment. Some of our drugs will make patients feel a little bit sick. In younger patients, so I know I've talked about it being a disease of older patients, but we certainly have younger patients having treatment. Chemotherapy can affect your fertility, so that will have a big impact on a young patient. So perhaps if we had a young man who had testicular cancer, we wanted to give him chemotherapy, we would need to think about fertility preservation before treatment. So perhaps we might do sperm storage, for example, so he could then go on and have a family in the future. Hair loss is common with some of the drugs, not with all drugs. Probably the most important side effect of chemotherapy that we see is the effect it has on the bone marrow, because it will affect your bone marrow, it will lower your white cells, it will lower your platelets. That does mean our patients are more susceptible to infection, so they need to be counselled very carefully about that. It can affect the GI tract, so anywhere really from the mouth down to the anus can be affected by chemotherapy. Your GI tract is rapidly dividing, and we've said that these are the cells that are targeted by chemotherapy. Some drugs can cause nerve damage, and not unusual to get nail changes. So when we're talking to patients about chemotherapy, it's really important that we manage their expectations, they understand some of the side effects of the treatment they're going to have. I mentioned radiotherapy, and this is also a very effective treatment for cancers, and radiotherapy in itself can be curative for many cancers. So for example, in my practice, we give men with prostate cancer radiotherapy, and that can be curative and they don't have to have an operation. And again, it's about trying to damage and destroy the DNA of the cancer cells. So by using radiotherapy, ionizing radiation to try and kill off those cells. And we've got really very good techniques now for radiotherapy these days, where you can deliver very high dose radiation to the tumour while trying to protect the surrounding tissues around that tumour. So very effective treatment. And this is just a picture of a patient having radiotherapy. So the machine is called a linear accelerator. They come in, they usually have daily treatment over a number of weeks, and actually very, very effective treatment for certain cancers. So when we talk about radical radiotherapy, we're saying, you know, this is likely to be curative treatment and maybe a good option for some patients who want to avoid an operation. So there's choices sometimes for patients in terms of what treatment they want to have. But like chemotherapy, radiotherapy is also going to have side effects. So if you use radiation to damage cells, you are going to get some damage to the surrounding tissues. So we would again counsel patients about some of the side effects they might expect. So again, if I think of prostate cancer as a good example, we give radiotherapy to the prostate, but a little bit of bowel, a bit of the bladder gets caught in that radiation field. So patients may get some side effects such as diarrhea or inflammation in the bladder, but that does tend to settle down. There can be some late effects with radiotherapy. So I've said it's a very good treatment, but over time, that damage that's been done to the normal tissue can cause some irreversible changes. So the tissues can get a bit stuck down and fibrosed, and patients even have a risk of a second cancer. So radiation itself is carcinogenic, it can cause cancer, and often that's quite a late side effect of radiotherapy. So all of these things come into the mix when we're thinking about treatment for a patient, because you know, if you've got a younger patient, for example, and you're hoping to cure them and they've got a good long life expectancy, the last thing you want is that you might introduce the risk of a second cancer. So all these things are taken into account when we make our treatment plans. So immunotherapy, I'm sure some of you may have heard about immunotherapy because it's a real sort of sexy topic at the moment in cancer. And this is looking at things from a slightly different perspective. So I've talked about chemo just killing everything in its path that's rapidly growing. With immunotherapy, we're trying to sort of manipulate the immune system to switch itself back on again. So we are seeing really quite encouraging responses to certain cancers with immunotherapy. So this is definitely something that's looking very promising for the future, because cancer cells are very clever and they can often evade our own immune system and switch it off, and we need to be doing something to get that back switched on again. And immune checkpoint inhibitors, absolutely the hot topic in oncology and cancer at the moment. And these are probably rather complicated slides, but if you just look at the text at the bottom, it's creating a situation similar to releasing the brakes in a car. So that's the way to think about it. So basically you're just sort of releasing the brakes and getting the immune system to start working again to try and target and kill off those tumour cells. So immunotherapy, is looking very, very promising for certain cancers. And this is an example. So this is a patient with malignant melanoma. So melanoma is a really challenging cancer for us to treat. It doesn't tend to respond very well to chemotherapy. And up until we had immunotherapy, actually these patients would do very badly really with treatment. But you can see here what a dramatic response this patient has had. So immunotherapy has really changed the treatment landscape for patients with melanoma, for kidney cancers. I'm using it in bladder cancer, it's used a lot in lung cancer. So you can hopefully see there's different ways that we can treat different cancers, and sometimes a combination of all of these different modalities is what's needed for our patients. CAR T-cell therapy, I think, comes under that umbrella of immunotherapy. And again, this is just using and manipulating the immune system to try and start to attack the cancer itself. So CAR T-cell therapy has been in the news a lot recently, particularly showing promise in the hematological malignancies such as leukemias and childhood cancers. So again, this is a really exciting field, and a lot of our researchers in the Cancer Institute are working on CAR T-cell therapy at the moment. And if anyone's particularly interested, this was a programme shown on BBC Two, and I'm sure you could probably find it on the iPlayer, the War in the Blood, A Cure for Cancer. And this was talking about CAR T-cell therapy, and this was based at UCLH and with a lot of our UCL researchers. And a little extract I had from one of our news channels here in the UK. So this was looking at CAR T-cell therapy in paediatric cancers, in cancers of children, and really looking very, very promising and potentially game-changing for some of our younger patients who had incurable leukemias. So it's a really exciting time to be a cancer researcher, because there's so much going on and so many new possible treatments for our patients. And the last sort of little bracket of treatment that we talk about, so I've talked about chemotherapy, radiotherapy, immunotherapy, targeted treatments as well, really coming to the fore for some of our patients. And again, this is about looking at the individual tumour and looking at perhaps there's a particular mutation there, or there's an overexpression of a protein, or there's something that we can potentially target which will really kill the cancer cell but perhaps not damage some of the normal cells. And there's lots of different things we can try and target. We know that cancer cells have normal blood supply, so perhaps their blood vessel formation, we can try and promote cell death, and we can deprive them of the hormones they need to grow. So there's lots of different ways that we can potentially target cancer cells and try and sort of kill them and starve them of what they need to survive. And again, this is always coming into the news. Herceptin was probably one of the first targeted treatments which was used in breast cancer. That's become a very established treatment now. These drugs are expensive though, so just putting it into the mix there, we've got to think about this. We're doing all this wonderful research, we do these trials, but in a common disease such as cancer, they're very expensive drugs, and there's a big impact on the health service in the UK. And again, in our course, these are things that we'll be teaching you about, because we need to think about the big picture and the social impact of the cancer diagnosis and the economic impact of new drugs coming through, and how do we make decisions about which patients are going to have access to all these fantastic new drugs we're developing. So my next question, true or false? So let me just, sorry. 40% of cancers in the UK are preventable. Want to have a poll about that? Shall we see what people think? 40% of cancers in the UK are preventable, which is quite a scary figure, actually. I think so. You know, a significant proportion of the cancers that we see in the UK are potentially preventable. And a lot of this comes down to lifestyle choices. So thinking about cancer in the UK, if we didn't smoke so much, if we kept, oh, there's the poll, sorry, it's just popped up on my screen. So we were about half and half there, which was, so about half of you thought this was true, but half false. So actually, probably a surprising figure for some of you. So actually it is true, we can prevent quite a significant proportion of our cancers. And it's obvious things, isn't it? It's, you know, not smoking, trying to maintain a balanced, healthy, sensible diet, staying safe in the sun, drinking less alcohol, all the things that we know we should be doing can make such a significant impact on our cancer incidence and prevalence. And prevention is always better than cure, isn't it? So what we want actually is that people don't develop cancer in the first place. So we should be educating people about lifestyle choices and the importance of you know, doing things that will help to protect patients from developing cancer. So be smoke free. So that's sort of obvious, isn't it? We all know about the risk of smoking with lung cancer. I've said I treat bladder cancer as well. The biggest risk factor for bladder cancer in the UK is smoking. So a lot of my patients are heavy smokers. So just by advocating being smoke free and trying to stop people from smoking, we could reduce cancer cases by nearly 65,000 a year. And you've probably seen all these things where there's been, you know, big government drives and NHS England trying to push this, trying to educate people and say, actually, this is a really bad thing to do. It's terrible for your health. It's not good for your children to be exposed to this. Look what's going into your lungs. This is a really bad habit. So you know, educating, using, you know, advertising campaigns to try and encourage people to have a better and healthier lifestyle. And, you know, it's quite interesting, you know, again, thinking about the UK, this is all intertwined with, you know, where people live in the UK and our socio-economic background as well. So we know, for example, in the more deprived areas of the UK, we see a higher smoking prevalence. In those areas, often people are more likely to be overweight. These are groups of patients who perhaps engage much less with healthcare professionals. They don't take up screening options, and we often see them presenting far later with a cancer diagnosis. So you can see, can't you, you know, your lifestyle, where you live, your normal daily habits, everything is intertwined in terms of your risk of developing cancer. And so that, again, is a lot of work for us to try and tackle this and to try and educate people about the importance of adopting a healthier lifestyle, recognising the signs and symptoms of cancer, and engaging very early on with intervention. And you can see here, again, we talked about lung cancer, for example. So in areas where there's higher deprivation and we know there's more smokers, we're seeing a much higher incidence of lung cancer. So certainly as an oncologist, where you work in the UK, your patterns of cancer may be very different, and it depends often on the sort of economic background and the social sort of makeup of the population of people that you're treating. And we think head and neck cancers, stomach cancers, esophageal cancers, all of these are linked with smoking and alcohol, so much higher in areas of social deprivation. But it's not just a UK problem, is it? So cancer is a global problem, but actually the patterns are slightly different if we think globally, because actually worldwide, infections are a really significant cause of cancer and linked to about a fifth of cancer cases we see. So we know some viruses, for example, might directly affect genes and have an effect on growth. Chronic inflammation can eventually lead to cancer. Particular infections may cause suppression of the immune system, and we've talked about how important the immune system is in trying to help cancer. So there's lots of different reasons why infection may contribute, and we do need to sort of think about this. This is not that you catch cancer as you do an infection. So a healthy person doesn't catch cancer, but it may be something that develops from chronic infection. And there's lots of different examples of this. So we've seen if you minimise certain infections, we can cut our cancer cases by about nearly 11,000 in the UK. But if we think globally, what a massive problem we face, and lots of challenges about how we do this. So we know hepatitis, for example, is a risk for primary liver cancer. Primary liver cancer is not desperately common in the UK, but globally it's a very, very major problem. HIV increases your risk of developing things like lymphoma and cervix cancer. And worldwide, we've got a big HIV population that are not on adequate antiretrovirals, so they're very likely to develop cancers. HPV, we know, increases the risk of cervix, head and neck cancers, etc. Now, we've got a good vaccination programme for HPV, but again, that's not a worldwide vaccination programme. So all of these things are going to contribute. Parasites, so schistosomiasis. I think I've seen 1 or 2 cases of bladder cancer caused by schistosomiasis in my practice, but again, globally, it's a much bigger problem. So we need to think also outside of the box, outside of what's going on in the UK, because this is very much a global issue and global problems. So just a little bit about our course. So we're trying to encourage people to think about cancer biomedicine, because we're trying to train the next generation of cancer researchers and scientists. And we think this is a great degree. So you're going to get equipped with all the skills you need to be biomedical science researchers for the future. And just a little breakdown of the course. So your first year is very you share it with the Applied Medical Sciences programme, so you need to learn about normal function first before you really can understand a disease process. So that's where you get your foundations in biology, biochemistry, physiology, etc. And you will have some introduction to cancer and its impact on society. And then really in year 2 and year 3, that's when we really sort of start to hone down on our cancer specific modules. So you'll learn about cancer biology. How does cancer develop? What are the hallmarks of cancer? How do we treat patients as we follow them through their journey? We talked about the global problem that is cancer. So we've got some new modules looking at pathogens and cancer and the role in cancer development. We've said radiation is a very common treatment for cancer, so we'll cover that in some of the modules. Clinical trials, we're always very keen to try new treatments, targeted treatments, the role of nutrition. So there's lots and lots of things that we cover in the 2nd and 3rd year of the course. But you've also got some optional modules as well. So if there's something that you're particularly interested in, we're always keen to open up some of the modules. So we've got students who, they've got interest in behavioural sciences or psychology, and they do modules in that. And your final year, you'll be doing your research projects, and that's an opportunity to really hone down on a specific topic and learn a lot more about it, and perhaps use your laboratory skills and work with some of the investigators in the Cancer Institute. And we get good feedback, so the students like interacting with other scientists and clinicians. The research project is popular because it's your chance to really do your own piece of work and write your dissertation. And we're trying to make sure that you're going to graduate from UCL with really good employability, and you're going to go on and get a good career from your undergraduate degree. And I've said about the diversity of the course as well, so we like to make sure that you've got some good choices in terms of optional modules. And our students currently, they're going on to do masters, they're going on to do PhDs, quite a few are thinking about graduate entry medicine. It's an opportunity to perhaps work in the pharmaceutical industry, to work with clinical trials. So hopefully you're getting a very good grounding from our course to stay either in a career in cancer research or some of these allied professions. So I think my last question. The UCL Cancer Institute has some of the best cancer researchers in the world. So let's have a little vote. And I hope we're going to get a full house for this. So we're doing well, a few more votes. So looking promising. So okay, so let's have a look. We'll end the poll and see what we've got. So fantastic. That's exactly what I wanted to see, and that is the right answer. So 100% of you think that the UCL Cancer Institute has some of the best cancer researchers in the world, and that is true. So that's very encouraging that you all think that. So why should you study at UCL and the Cancer Institute? So actually, I mean, this is the truth, that we are actually one of the best research institutes in the country. So in terms of international cancer research, UCL was ranked first in Cancer Institute, but actually as a university, we're ranked within the top 10 in the world. So I know I'm blowing our trumpet a little bit, but I think we've got the grounds to do that. So this is a great university to come to, and a great research institute. And we're trying to make sure that we have this great approach between those two buildings you can see on that slide here. On the left-hand side is the Cancer Institute. On the right-hand side is the Macmillan Cancer Centre, where we see our patients. So you can see how closely we're intertwined, and it's this true translational work from bench to bedside that we're trying to encourage. And what you might do one day in the laboratory, we're hopefully translating that into patient care for the future. And in a few years' time, if you do that course, this could be you. So this was our first in-person graduation ceremony this year for our Cancer Biomedicine BSc graduates. So that was a lovely day. Great to see everyone in their glad rags and all dressed up. And that could be you in a few years' time if this is a course that you're interested in. So the next 10 to 20 years are really going to be groundbreaking, I think, in developments of new treatment for cancer. So we think you should become the cancer researchers of the future and help us make discovery, and perhaps most importantly, save lives. Okay, so I'm going to come off my slides there. So I'm sorry, I had a few technical issues there with the internet, but hopefully that didn't disrupt the session too much. So over to you, Emma, I think.
Thank you so much, Dr. McGovern. Hopefully that's given you all sort of an idea of what the course is going to be like. But if you have any more specific questions, either about the application, cancer biomedicine, life at UCL in general, please just put them in the Q&A box on Zoom. So as you guys are typing your questions, we can go through some questions we received prior to this event. So first of all, Dr. McGovern, do you have any tips for the personal statement?
Oh, I always get asked this. So, I think, we want students who have got a genuine interest in cancer as a field. So, a lot of the personal statements talk about perhaps, you've had personal experience of someone with cancer, or you've perhaps done some work experience and seeing cancer patients being treated, or, why you think this is an interesting field to go into. So, and think, we're thinking holistically. We don't just want people who only want to think about the academic side of things. We're looking for students who are going to enjoy UCL, they're going to contribute to the student experience. So, just a genuine sort of interest in the topic, and it's not that they just can't think of anything better to do. So a real appetite to learn and to develop and to be a researcher.
Perfect, thank you so much. If I can try and remember what I did in my personal statement, I can try and give some tips. I think I didn't have any lab or research experience that was very extensive before applying, mainly because of COVID, so everything was online. But I just researched independently and read lots of articles and books on cancer biology, done a few free online courses, and then wrote about them in my personal statement and also my motivations for applying. So yeah, you don't need to do anything too dramatic, just demonstrate your interest and your passion for it and you'll be okay. Another question, how have you found commuting between campuses? So for those of you who don't know, a lot of our lectures in first year are based at the Royal Free Hospital. That's around a 20-minute tube journey for me I was living in UCL accommodation, so close to the main campus. I found it okay. It's not too bad. And there's lots of stuff to do around both of the campuses. So yeah, I enjoyed it. Another question, I guess this is kind of similar to the personal statement one, but do you have any top tips for someone applying?
No, I think as you say, it's about just trying to show that you're motivated. You were a great example. So in time of COVID, it was difficult to do things, wasn't it? But you got online, you did some courses. So just using your initiative and just different ways of demonstrating an interest. I appreciate it is difficult at the moment to get work experience or to do any shadowing, and that wouldn't necessarily preclude anyone. But getting online, doing something like that, I think that shows you're really motivated. So that's a good thing to do. Okay, good. We have a question in the Q&A box.
someone is applying for medical school and they'd like to put this as their fifth choice, do they need to submit an extra personal statement? And if an extra personal statement isn't required, is it necessary for them to include any cancer-related experience in their personal statement?
I mean, so it's not uncommon that we have this scenario where we have students using 4 of their choices for medicine, and then we're the 5th. So I think you can incorporate us into the personal statement for medicine as well. So because obviously there's an overlap, isn't there? So we do understand that. So you know, it may be that some people are interested in medicine and they've got a particular interest in cancer or oncology. So something like that could be incorporated in.
Another question from before the event, what's been my favorite module so far? I would definitely say from first year, it was the Cancer Medicine and Society module. That's the one cancer specific module you'll have in first year. And I really enjoyed it just because it was like such a different sort of perspective on cancer compared to like all of the really scientific and stuff that was focused on like biology in my other modules. This was more things like cancer patient psychology, art therapy, music therapy. And that's something I'd kind of like to go into in the future. So I definitely found that one really interesting. But just most of the modules in first year were really good because I know that I want to go into cancer research, but it was really nice to get like a understanding of a lot of the general aspects of biology as well. So it wasn't purely cancer biology from the start of the degree. What tend to be the most popular modules?
Well, so if you think about in second and third year, some are core modules. So you know, you'll be mandated to do certain ones. So because I think clearly you need an understanding of cancer biology, some clinical aspects of the trials, but a lot of the immunology and infection modules I think are quite popular with students. Nanotechnology, there's quite a lot out there. The module catalogue for UCL is huge, so that's why we try to actually accommodate students who've got particular interests. So you know, we may have some students who are thinking about graduate medicine, so they're quite interested in surgical modules, so I do try and accommodate wherever. So the core modules, you know, you'll do anyway, and then it's sort of, you know, if you've got particular interest in other things.
Yeah. Someone has asked, what's the difference between biochemistry and biomedicine? I'm not 100% sure in the biochemistry course at UCL, but definitely this has a lot less chemistry in the course. So if you have a specific interest in chemistry, maybe biochemistry would be more suited to you. Do you have any more ideas?
Yeah, I suppose, but I mean, biochemistry, I would think is very much more cellular level, isn't it? So, you know, you're thinking about, I don't know, Krebs cycle, all this sort of stuff that you learn. I think biomedicine is starting to see how do we translate that into how we treat patients and how we diagnose diseases and how we treat diseases. So, so perhaps it's a little bit more patient oriented, I'd say, biomedicine than biochemistry.
Yeah, I'd agree. A lot of our modules in first year, compared to my friends who are doing, say, biology or biochemistry, we get a lot more of like the perspective from like clinicians and how it's treated. Yeah. Someone's asked, if I were to do biomedical science at UCL, is cancer biomedicine a choice to switch to if I'm specifically interested in it?
So I don't think we'd be encouraging to do one to plan to switch to another. So I think you know, at this point, you know, students should make the choice about what they'd like to do. So we do have some students switching, but it's not necessarily what you should be doing. So if your interest is biomedical sciences, then that's something to do. If you're interested in cancer biomedicine, that's something to do, because there's no guarantee that once you're on a course, there's going to be capacity to switch over. So I wouldn't want to give the you know, the impression that you can just do one and then switch to something else. So I know it's difficult. Sometimes you have to really know what you want to do, but so there's a little bit of room for manoeuvre, but I wouldn't be encouraging that as a route to application.
Someone else has asked, is there a way to transition from biomedicine to medicine after the first year? Because I know some unis offer that.
No, not into medicine. I think again, it's this is not a route into MBBS. So again, it's very separate. So we've certainly got some of our students who are planning to apply for graduate entry medicine, but that will be on completion of their degree. So and then that's going in as a graduate. So it's not a route to sort of switch after a year.
Um, yeah. Another question is, how did you make friends at UCL? I was definitely very nervous before coming. I come from like 3 hours away from London, so I know a lot of people come from further even than that. But I was scared I wouldn't be able to make any friends in a new city. But I just joined a lot of societies in my first week, went to a lot of UCL's events that they offer in your first week. And also because this course is quite small, you get to know everyone on the course really well. So it's such a nice sense of community. And I found it pretty easy to make friends here. So yeah, just pursue all of your interests, go to lots of societies, and you'll find the right group of people. What books can you recommend to read?
I always say the Emperor of all maladies at this point, because that, I suppose, that is the typical biography of cancer, isn't it? So that's a good book to read, but you actually learn about that anyway. So the module that Emma talked about, Cancer Medicine Society, we actually look at that in terms of the dramatization of that. So you watch the story of cancer developing. I wouldn't always say don't get too bogged down with reading prior to the course, because you'll get a reading list once you start, and you'll be guided about what things to read. So but something like The Emperor of All Maladies is quite a good book, because that is the biography of cancer, and it's how we got to today, from 100 years ago, whatever.
Yeah, I read a really nice one before applying. I think it was called One in Three by maybe Adam Wishart. And it kind of like told a patient's story with cancer and then included the history of cancer medicine alongside that. And I found that one really interesting. It's quite similar to Emperor of All Maladies. Um, if the A-level entry requirements are not met, can the personal statement help someone be accepted?
Oh, I think not really. I mean, we're not directly involved with admissions, but it's a very competitive course, so the entry requirements do need to be met, and that won't change just on the basis of the personal statement.
Someone's asked, can you recommend any work experiences, either online or in person, that's specific to cancer research?
It is tricky, I think, at the moment, because even though we think we're coming out of the pandemic, there are still some restrictions. So I think at your stage it would be really quite difficult to get work experience in the lab. It's not what we're looking for either. We're not expecting you to come in with that sort of experience. Some hospitals maybe, and some universities, you can look on their websites, and they do have some information about how you can do some work experience. So that might be worth exploring. But it's been really challenging. If I think about in our own practice, for example, we haven't really had medical students even in our clinics for the last few years. So I wouldn't put too much focus on experience, because I think we all appreciate it's been very difficult to get that with the current situation.
Yeah, I would just recommend instead of like applying for things, because that can be very difficult, if you go on websites like Coursera, FutureLearn, there's a few online courses which you don't need to pay for, and they will teach you about cancer biology or research techniques. So that was literally the only experience I had when I applied, and I found that really useful. How should you organize yourself in the first year? I wouldn't worry too much. First year isn't too intense. It's a nice transition. I did A levels before, but I know people who've done IB, and we found that first module that we have, Foundations in Human Physiology and Cell Biology, it's like a very good transition from your high school study to university level. So just figuring out what works for you during high school and carry on using those techniques at uni. And if you have free time, we have a ton of really lovely libraries here, so spend time there. And yeah, you can also do group study sessions with your friends, so I found that very helpful too. How do you manage your finances while studying? I know London can be a very expensive city to live in, and it's very tempting, like if you want to go out with people in your first week, make friends, you're going to end up paying quite a lot. So make sure that you, whether you have like a student loan, make sure you do like a spreadsheet budget, figure out how much you want to spend per week, and try not to go over it. UCL also offers a lot of scholarships and bursaries. So I'm sure if you Google search it, you can find some financial support if you would need it. If you fail a year, are you able to retake the year?
Oh, I think that don't come into it thinking you're going to fail the year. That's the thing I would say. So I think it's very unlikely really that would happen, to be honest, because I think if we had a student who was perhaps struggling, hopefully that would have been identified a lot earlier and we would help and intervene. If you happen to fail a module, then you can resit that module in the sort of late summer assessment. But to be honest, honestly, I can't think of the last time we had a student fail a year, because we would hopefully have helped that student much earlier. So if you get in and you're engaging, there's so much support there to make sure that you get through your exam. So I wouldn't worry about that too much.
Somebody asked, which are the best halls of residence? Basically, when you apply to accommodation at UCL, you can't actually select one. So I wouldn't get your hopes up for getting a specific halls or anything. I have heard the best ones are Astor. I was in Schaefer House, which is like 10 minutes from campus walking, so that was a nice one. Garden Halls is another really nice one, but it's quite expensive. Yeah, but most of the UCL accommodation is nice, and it's all fairly close to campus, apart from a couple which are maybe like a 40-minute walk away, but it would be very rare that you would get those ones. But yeah, when you apply, you just put in preferences. You can't, like, preferences like how much you want to spend, single, ensuite, etc. You can't pick a specific hall. So yeah. Which year does UCL start to get students into clinical situations, and what should you expect?
So, I mean, this isn't medicine, so it's a separate degree. So the clinical aspects are probably more about the teaching that you receive as opposed to situations you get into, I would say. So let's say, for example, in your second year, you'll do a module called Clinical Cancer. And that is run by working oncologists, and you'll follow a patient, a hypothetical patient, through their treatment, but it's not that you're going to be on a ward seeing that patient. And then in your third year, again, some of the projects that you do may be very clinically focused. So again, it might be going into the hospital electronic patient record and gathering data about a set of patients. So we may try, and again, this has been a problem with the pandemic, that we might get students to come in and sit into clinics, perhaps in their final year, just to see how it all translates, into the real world in terms of clinics. But there isn't meant to be a big clinical component to this in terms of the course. This is very much more on the scientific and research side, I would say.
There's a very big question here. Do you think we'll be able to cure cancer, and what are your predictions for the future?
Oh, what a good question. Do you know, I have to say no. I don't think we're going to cure cancer, because I just think it's nature's way of sort of, of changing things as we get older. I think what will happen is cancer will become much more of a chronic disease. So a little bit like the way we think of diabetes or, respiratory diseases, that patients live with their diagnosis and actually live very good quality life and have longevity. But will we get rid of it entirely? I don't think so. I mean, I think where our outcomes are getting better and better, and I think some cancers we will be close to eradicating. We talked about cervical cancer, for example, with a successful vaccination program, but equally I look at something like pancreatic cancer, and our treatments haven't really moved on much in the last sort of 15-20 years. So some things are still very, very challenging for us. So maybe I'm wrong. Maybe one of you out there is going to be the person that cures cancer, and that would be fantastic. But I think it will probably still just keep adapting, and it's something that we live with, and our outcomes get better. But I'm not sure we'll get rid of it entirely. Emma, what do you think?
I'm going to have to think the same as you. Just because there are so many different diseases and they're all extremely different to each other. I don't think there'll ever be one specific cure, definitely, but we should be hopeful.
Yeah.
Someone asked, will this session be recorded? Yes, it will be recorded. You'll get sent the recording after this. I'm assuming this question is for you. What are some of your goals that you want to meet in your career?
I thought it was for you, Emma.
I don't know. Well, we can both answer it.
We can both answer it, yeah. I mean, to be honest, I've achieved an awful lot of what I wanted to do. You know, I've been a consultant now for 12 years. I absolutely love working with patients with cancer. It's such a privilege, you know, particularly in the cancers that I treat, so prostate cancer, you know, men can live a very, very long time. So you get to know your patients really well, you get to know their families, and you sort of go on that journey with them, and it's wonderful. It's an absolute privilege. And you know, the treatments are always changing, so it really is a very dynamic specialty, because you know, I look back over the last 12 years and the treatment I'm giving today for prostate cancer is totally different from what I was doing 10 years ago. So it's always evolving, it's always improving. So, you know, if I can carry on, I run trials, if I can carry on doing that, you know, developing some new treatments, I'm quite happy with my goals and achievements. I'm getting old now, so, you know, I'm not quite as energetic as I used to be. So, but Emma's got her whole career ahead of her, so you must have lots of goals.
Well, you've achieved a lot. I feel like this is going to be really much worse than what you've done. But I'm definitely very interested in pediatric cancers. And over the Easter, I did an internship in a lab looking at brain tumors. So I'm really interested in neuroscience as well. So ideally, I would do a master's or PhD focusing on pediatric brain tumors. And then I definitely know I want to have some sort of work on the side where I can make a difference more personally with cancer patients. So I do a lot of dance and yoga, so I would maybe want to do dance movement therapy for cancer patients, either like volunteering or working on the side of research. And then like very far into the future, I'd like to be involved in teaching as well, but we'll see. I keep changing my mind on my career plans, but yeah. I know a lot of people in this course want to go into like medicine as well afterwards. Do you want to discuss the sort of things people tend to do afterwards?
Yeah, I mean, it is definitely one of the things that some of our students go on to. So we've got certainly a few in our final year at the moment, and some who've already applied for graduate entry medicine. But we've got quite a lot who are very focused on being a researcher. So they perhaps go from our degree to do a master's, and then quite a few now of our first cohort. So because we're only a 4-year-old course at the moment, they're doing PhDs. So it's great that, you know, people are staying within the realms of cancer research, and they're staying in careers in science, and there's quite a lot of opportunities out there. So you know, it is about trying to equip our students with all the skills that they need and the knowledge that they need, and you know, you will leave with a good grounding in science. So perhaps even at the end of it all, if cancer is not for you, you'll have laboratory skills, you'll have other things that you can apply to other subjects and carry on in academia if that's what you want.
Yeah. Just to let you know, we have about 5 minutes left. So if anyone has any last minute questions they want to get in, please send them now. Someone's asked, how do you recommend taking notes, and any tips for taking notes in lectures? I was actually just asking my friends about this today because I feel like I don't have a really good system for it. For me, the best way I can memorize stuff is if I write it down. So I just tend to get through a lot of notebooks, handwriting notes. But I also last year used a virtual flashcard app, and made flashcards as I went along in my lectures, and that was definitely helpful when it came to studying for the exams. I know lots of people like to type up their notes and make them look really pretty because that motivates them. So if that works for you, then do that as well. What other thoughts of people who are doing this course?
Well, we get good feedback. So generally, I think people have enjoyed the course. I think they like the option to work with clinicians and with scientists, and you know, the Cancer Institute does have a very good reputation, so it's a good place to work. So I think generally our students are relatively happy. What do you think, Emma?
Yeah, definitely. I always say that doing this course and coming to UCL was like the best decision I've ever made. I enjoyed it. Like thought I would enjoy it, but I was also very nervous. But it turns out that it's literally incredible here, and I'm really interested in everything. It's like the perfect course for me. So if you're interested in even just general biology or cancer research, I would definitely recommend doing this course. And the professors here are great as well. So I feel like we could end it on that note. Oh, I can see one more question, which maybe we have time to answer. Do your lessons consist of any lab work? Yes, I think I think it's every 2 weeks in first year you'll have a lab. Do you know about second and third year?
Yeah, so depending on the modules that you do, so there will be some lab techniques that you'll learn, and then hopefully then by the time you go into year 3, you'll have had enough experience that you can go into a lab and perhaps do a wet lab project for your dissertation. So you will get those skills, and because of the optional modules as well, you can pick particular modules that have got lots of lab components to them if that's what you're interested in.
Yeah. So thank you all for your questions and for interacting in this event. We're sadly out of time and we'll have to leave it there, but we would really appreciate if you could leave us feedback. We'll put the link to a survey in the chat now. So yeah, thank you all for joining, and thank you to Dr. McGovern for an excellent session. We're going to end it there, so have a great evening, everyone.